Laughlin syndrome in the sarcoidosis involves what? Typically, in the case of Laughlin syndrome, there is a lymphadenopathy, anterior uveitis, polyarthritis with hilar adenopathy, and erythema nodosum. So this important conjunction called Laughlin should not be forgotten. There also can be ankle inflammation, arthralgia, pulmonary involvement and other things. Usually it is an acute disease, Laughlins. It has got excellent prognosis. Typically it will resolve by about 6 to 8 weeks. How will a sarcoidosis patient present to you, doctor? Basically, you have taken a chest radiograph, there is a bilateral hilar adenopathy, then the whole story begins. 3 common differential diagnoses for hilar adenopathy, tell me. Number 1, TB in this part of the world. Number 2, it can be a lymphoma. Number 3, it can be the sarcoidosis, is something that should not be forgotten. So basically, you have the lymphadenopathy, polyarthritis, paratracheal lymphadenopathy and arthralgia. So all these are the features of the Laughlin syndrome. Zidovudine toxicity typically is increased by what? So we use left and right the zidovudine in the management of HIV patients. So we need to know all the drug interactions with the zidovudine, doctor. So paracetamol competes for the glucuronidation of the zidovudine, hence the toxicity can increase. So you can't stop a HIV patient to have a fever. There are multiple n number of reasons why he can have fever. He may be having a underlying infection with a fever, tumor with a hypermetabolic state with the fever, many causes for the fever. So there you have used typically the paracetamol, it can interact. Similarly, the nephrotoxic drugs can increase the toxicity. Myelosuppressive drugs, probenecid and azole antifungals, they all inhibit the metabolism of the zidovudine and can worsen its toxicity, is what need to be remembered. So let's go to the next question. Regarding levodopa, what is true? Can the protein diet can increase absorption or interfere with it? Yes. A patient with Parkinsonism happened to have a sumptuous chicken 65. Can there be any effect upon the absorption of the levodopa? It can have. So that's the reason interactions of the levodopa, adverse effects of the levodopa is a favorite question for the examiner, doctor. It can have cardiovascular effects, it can have the hallucinations, but more common with the levodopa, the GIT, nausea and all these features are much more common. Adverse effects of the levodopa is what need to be remembered. And if you give pyridoxine to manage the tuberculosis, anti-tuberculous therapy in a Parkinsonism patient, that pyridoxine can go and interfere with the metabolism of the levodopa, increase its metabolism and decrease its efficacy. So pyridoxine and the levodopa should not be basically forgotten. They both are closely related to each other. We have studied pyridoxine is a part of which set of enzymes, doctor? Biotin is seen in carboxylases. Vitamin B6, pyridoxine is seen in decarboxylases. Is levodopa has anything to do with decarboxylases? Definitely. So that is the reason pyridoxine increases the metabolism of the levodopa. This important drug interaction should not be forgotten. Now what are the features of the upper motor neuron disease versus lower motor neuron disease? Fasciculations, wasting, diminished DTR and absence of any Babinski. These are all the features in the case of lower motor neuron disease. Whereas upper motor neuron disease, spasticity, increased deep tendon reflexes and these are the presence of the Babinski. These are all the features of the upper motor neuron disease is what it is remembered. So flaccidity is seen in lower motor and spasticity is seen in the case of the upper motor and rigidity is seen in the case of extrapyramidal upper motor. What are the 4 extrapyramidal tracts? Vestibulospinal, tectospinal, rubrospinal, reticulospinal, you should not forget. Whereas corticospinal is called pyramidal tract. That's good. Now, what is the root value of the patellar reflex, doctor? Typically, it is L3, L4 is what you call the root value. How about the ankle reflex, doctor? S1 is the root value. How about the biceps? C5, C6. What is the triceps? C8, T1. Okay. So all these things you should not error on these things. Microvesiculous steatosis typically is not seen in the case of the methotrexate. So catch up all that list of micro versus macro. You need to remember hook or by crook. In enteric fever, when will blood culture will be positive? Basu. B for blood culture first week, A for agglutination, Vidal is in second week and stool in the third week, urine in the fourth week. Cirrhosis of liver, collagen is laid down basically by, is it ito cells or hepatocytes? So following liver injury, the interstitial type 1 collagen will be activating the hepatic stellate cells, which will be perpetuating the damage of the hepatic tissue. The stellate cells are also called ito cells, is what need to be remembered. So they are the ones which will be laying down the collagen. And they also store vitamin A, is what need to be remembered. And this is the typical appearance of a patient who has got a hypervitaminosis A, where all his ito cells, which are identified by these fat vacuoles, they got basically hypertrophied and increased in their number, is what I want to underscore to all of you. Where do you find tram track appearance, doctor? In the case of membranous nephropathy or membranoproliferative nephropathy. Good. So let us talk 1-2 comments about each of them. Focal segmental glomerulosclerosis. Basically there is an interposition of the mesangial cells and the matrix into the capillary wall, and that will cause the capillary wall basement membrane to become thickened, and that gives the tram track or double contoured appearance for the capillary wall, and it is best appreciated by the methenamine silver stain, is what need to be basically remembered. So there are 2 types of glomerular pathologies, doctor. Those pathologies that lead to the GBM thickening, and those pathologies that increase the mesangial cell number. Accordingly, you have got membranous diseases of glomerulus where GBM is thickened, or proliferative type of diseases where mesangial cell number, cellular number is increased. Some diseases have both, membranoproliferative diseases. This basic distinction you need to basically know. So this is a classical example where the membrane, GBM membrane has got thickened, is what need to be remembered. So membranoproliferative glomerulonephritis, if you take a stain section, glomerulus will show the mesangial interposition with a double contouring of this basement membrane, and it is surrounded by a lot of subendothelial deposits, is what need to be remembered. So now you know where the tram track appearance is typically seen. Once there is a thickening of the GBM with the associated proliferative component, is what you can see. So do you like to put membranous or membranoproliferative at the end of all this?
Type 1 MPG.
Yes, I mean type 1 and type 2 anyway is not given. Yeah, it's not membranous, definitely not. I mean, don't take this, take discussion into consideration, not the answers mentioned over there. Okay. Are you doing that? I mean, you are quite sure about it. Good. So in hemolytic uremic syndrome, what will happen, doctor? How to differentiate hemolysis, which is autoimmune in origin, versus that of the microangiopathic hemolysis? In the case of the autoimmune hemolysis, Coombs test will become positive. Why? Because antibodies, antigens are combining each other, complement is used as chutney, and finally the RBCs are taken and broken down. That's the reason there is a development of Coombs positivity. Coombs negativity, with a normal complement, with the hemolysis occurring, you need to think of a microangiopathic hemolytic state, which is seen in the case of the hemolytic uremic syndrome. Hence, the serum C3 being low is not a feature really. Neuropathy with a predominant motor involvement. Where do you see it, doctor? In the case of what you call lead, typically it will be a pure motor neuropathy involving only the upper limbs, is what you classically see. Quickly talk about the GB syndrome, doctor. It is ascending, progressive weakness, starts in the lower extremities. It is almost always symmetrical, which differentiates it from poliomyelitis, which is more asymmetrical in nature, and maximum severity will be developing within 2 weeks after the initial symptoms. That is, the fever will be there. After 2 weeks, GB syndrome will be starting, and usually it stops by itself within about 5 weeks, is what I want to underscore to all of you. But during its clinical illness, while it ascends up, if it involves the diaphragm, the patient can go into respiratory paralysis, is what you need to basically remember. And it involves even both the sensory system also, hence paresthesias develop. A patient with GB syndrome classically will be suffering from a severe pain because of this paresthesias, so which you can't forget unless you treat one patient. And pain typically in the thighs and shoulders is a classical feature. How about leg neuropathy, doctor? Wrist and finger extensors become involved, intrinsic muscles of the hand become involved, is what need to be remembered. How about acute intermittent porphyria? It is also predominantly motor, and it can mimic the Guillain-Barré, And here the weakness starts in the lower limbs and ascends just like in the case of the Guillain-Barré, but they will also have associated autonomic neuropathies. There will be hypertension, tachycardia, neuropsychiatric manifestations, in addition to the weakness of the lower limbs, which is in ascending manner, that will make you to think of acute intermittent porphyria. Chronically getting exposed to the arsenic leads to development of a painful paresthesia is what need to be basically remembered. So finally, what is your answer, doctor? Neuropathy with a predominant motor involvement is seen in lead intoxication. Acute intermittent porphyria, GBS involves both, that is both sensory and the motor, doctor.